Hello, everyone, and welcome to our module on hemoglobin. Let's start by talking about how oxygen is transported in our bloodstream. So the oxygen content of our blood comes from two sources. There's a small amount of oxygen that's dissolved in the water portion of our blood, but then there's a much larger amount of oxygen that's found in our blood bound to hemoglobin. The dissolved oxygen only makes up about 2% of the total oxygen content of blood, and the amount of dissolved oxygen in our blood is determined by Henry's law. Henry's law says that the dissolved oxygen is equal to the solubility of oxygen in blood times the PaO2. And PaO2 is the partial pressure of oxygen in our arterial system. You can basically think of it like a concentration of oxygen in our arterial system. And so this dissolved oxygen makes up a very small amount of our total blood oxygen, only about 2%. And the amount that's dissolved is directly related to the PaO2. When the PaO2 goes up, there's more dissolved oxygen. When it goes down, there's less. Now, if we had to rely on dissolved oxygen to meet our metabolic needs, we would not survive because it's such a tiny amount. But luckily, we have hemoglobin, and lots of oxygen found in our blood is bound to hemoglobin. 98% of the total content of oxygen in our blood is bound to hemoglobin. But the thing you have to understand is the amount of oxygen bound to hemoglobin depends on multiple things. So it depends on the PaO2, just like dissolved oxygen, but it also depends on the concentration of hemoglobin found in our blood and the percent of that hemoglobin that is saturated with oxygen. So all three of these factors contribute to how much oxygen is carried in our blood by hemoglobin. And later in this video, we'll talk about the concept of SaO2, and this essentially refers to the total oxygen bound to hemoglobin in our blood, and it's dependent on these three factors shown here. We'll come back to the oxygen content of blood in a minute, but let's talk briefly about the structure of hemoglobin. So hemoglobin is made up of two components. There are globin chains and heme molecules. So each molecule of hemoglobin has four globin chains. The globin chains are proteins, and they come in a number of subtypes. There are alpha chains, beta chains, gamma chains, and delta chains. And every hemoglobin molecule has four chains made up of two pairs. So for example, it may have two alphas and two betas, or it may have two pairs of other globin chains. Associated with each globin chain is a heme molecule. This is what a heme molecule looks like right here. It's not a protein, it's a non-peptide molecule. It contains iron in the middle, surrounded by this structure, which is called a porphyrin ring. And the iron in the middle of the heme molecule is what can bind oxygen. And so each globin chain has one of these heme groups, and each of these heme groups can bind one molecule of oxygen. So that means each molecule of hemoglobin, each set of four chains and four heme molecules, can bind four molecules of oxygen. There are different types of hemoglobin found in the human body depending upon which globin chains make up the hemoglobin molecule. So hemoglobin A is the adult type of hemoglobin. It's the most common type found in adults. It makes up 95% of all hemoglobin in adults, and it's made up of two alphas and two beta chains. The less common adult type is called hemoglobin A2. It only makes up about 2 to 3% of adult hemoglobin, and this hemoglobin is made up from two alphas and two delta chains. And then hemoglobin F is the fetal hemoglobin that's dominant in the baby in utero. This is particularly good at holding onto oxygen in the environment of the uterus. We'll talk more about this later. And hemoglobin F, the fetal type, is made up of two alphas and two gamma chains. And so a theme here is that all hemoglobin has two alpha chains. It's the other two chains that determine what type it is. If the other two chains are betas, you have hemoglobin A. If they're deltas, it's A2. And if they're gammas, it's F. Okay, so now that we've gone through all that, we can talk about oxygen-hemoglobin dissociation curves. This is an example of an oxygen-hemoglobin dissociation curve shown on the screen here. The y-axis is the percent saturation of hemoglobin. It ranges from 0%, meaning no hemoglobin is bound to oxygen, all the way up to 100%, meaning every hemoglobin molecule has four oxygens bound to it. On the x-axis, we have the partial pressure of oxygen. And so as we move up the x-axis, a higher and higher partial pressure, we saturate more and more of the hemoglobin until eventually we reach a point at a certain partial pressure around here where 100% of the hemoglobin molecules are bound to oxygen. And so for the next bunch of slides in this video, we're going to talk about these dissociation curves, features of these curves, and things that shift the curve to the left or the right. So the first thing we're going to talk about is why this oxygen-hemoglobin dissociation curve has this S shape like this. And the reason it has this S shape is because of the way hemoglobin binds to oxygen. So the four heme groups in hemoglobin do not simultaneously oxygenate. When the first oxygen molecule binds to a heme molecule, it increases the affinity of hemoglobin for the second molecule. And then the second increases the affinity for the third, and the third increases the affinity for the fourth. And in fact, the affinity, in other words, the tendency to bind oxygen for the last oxygen is 300 times the affinity for binding of the first oxygen. So it's much harder to get that first oxygen bound. It's much easier to get that last or fourth oxygen bound. And this phenomenon I've described here is called positive cooperativity. It's a feature of hemoglobin, and that's what makes the oxygen hemoglobin dissociation curve S-shaped. If it weren't for positive cooperativity, the curve would simply look like this. But it has this S shape like this, and that's because of the cooperativity and the changing affinity of the heme groups for oxygen. Hemoglobin is an example of an allosteric protein. So the term allosteric means other site, and allosteric proteins can bind multiple substances, and when one site binds, this influences binding at the other sites. Most allosteric proteins are multi-subunit proteins, and hemoglobin is an example of one. And oxygen cooperativity, which we just talked about in the last slide, is an example of a positive allosteric effect, meaning binding at one site positively influences the likelihood of binding at the next site. Okay, so now let's go back to these oxygen hemoglobin dissociation curves like the one shown on the slide here, and I want to point out a couple of things. So in our lungs, the PaO2 is about 100. So when we're in the lungs, the hemoglobin is usually fully saturated up here near the 100% line. In our tissues, the partial pressure of oxygen is about 40, so when we get to our tissues, the percent saturation is much lower, somewhere down here around 60. What this means is that as the blood moves from our lungs to our tissues, we offload all this oxygen right here as hemoglobin goes from 100% saturated to 60% saturated. So that's the first thing you need to appreciate about these curves. The second thing you need to know is that these curves are often defined by a number called the P50, and the P50 is the PO2 that 50% saturates hemoglobin. So in this case, if this is the 50% saturated mark, we would go out to here and go down and say that for this curve shown on the slide, the P50 is about 30. So you just need to understand that concept of the P50 of a dissociation curve. You should be aware that globin chains can assume two formations. One is called the taut form. This tends to release oxygen, and this is the favored form in tissues. It allows for more release of oxygen. The other form is called the relaxed form. This tends to hold on to oxygen. This is the favored form in the lungs, and this allows for more binding of oxygen. And so if we go back to this slide, here at a PO2 of 40 is what the tissues have, and this is where you're going to find lots of hemoglobin in that taut form. Up here is where you're going to find it in the relaxed form because this is a PO2 of 100, and that's what you find in the lungs. Okay, the next thing you need to appreciate about these hemoglobin dissociation curves is that they can shift. So the affinity of hemoglobin for oxygen is not fixed and it can change. And the hemoglobin molecules are modified by the environment inside the red cells. And so depending upon the environment inside the red cells, the dissociation curves can shift to the right or left. So if you look at this graph on the slide here, if we call the blue curve here the baseline curve, certain elements inside the red cells can shift that curve either to the right where this red dashed line is or to the left where this green dashed line is. And those shifts are going to have implications for how easy or hard it is to take up oxygen and offload oxygen in the tissues. Okay, so let's start by talking about what happens with a rightward shift of the hemoglobin dissociation curve. So if you look at the bottom right side of the screen here, this blue line right here is the normal hemoglobin dissociation curve. And so if we look at the lungs, which have a PaO2 of about 100, we have 100% or completely saturated hemoglobin. And then if we look at the tissues, which are here at about 40, we have hemoglobin that is about 75% saturated. So I've put these numbers here on this table. But now let's look at what happens when we right shift the curve and we move to this red line here. So in the lungs where the PaO2 is 100, we're still 100% saturated even on the right shifted curve. So nothing has really changed in the lungs. But down in the tissues here where the PaO2 is 40, now our percent saturation is here, which is only about 50. So what this means is that by shifting the curve right, we have offloaded more oxygen. In the normal setting, the normal curve, we went from 100% saturated hemoglobin to 75%. That's a delta of 25. But after the right shift, we went from 100 to 50. That's a delta of 50%. So the bottom line here is that rightward shifts help offload significantly more oxygen in the tissues, and that's the benefit of rightward shifting the hemoglobin dissociation curve. And so on this slide, I've summarized those points, okay? Rightward shifts release O2 to the tissues. Instead of dropping from 100 to only 75, when we right shift, we drop all the way to 50 and offload much more O2. And so that's what you can remember, right shifts release O2. Also notice that when we rightward shift, the P50 increases. So the original P50 here was about 25, but when we shift, the P50 moves up to around 30 or 40 or so. And so all rightward shifts increase this P50. Just make sure you understand that. When you shift the curve to the right, that favors the taut form of hemoglobin. We talked earlier about how the taut form is the form that more easily releases oxygen. So hopefully it makes sense to you that rightward shifts of the hemoglobin dissociation curve, which tend to release O2, will favor that taut form. And there are a number of things in the body that cause rightward shift, and they're all generally related to rising metabolic activity. So if there's more metabolic activity and more CO2 is being produced in the body, that will shift the curve to the right. If there's higher body temperature from metabolic activity, that will shift the curve to the right. And then anytime there's more CO2, that can lower the pH, and so lowering the pH also shifts the curve to the right. And the idea here is that all these things indicate a need for more oxygen, and so they shift the curve to the right so that more oxygen can be released from hemoglobin. So if you want an easy way to remember this, you can just remember the rightward shift is associated with taut and releasing of O2. And then also don't forget that all rightward shifts increase the P50. And then if you understand rightward shifts of the hemoglobin dissociation curve, then it's very easy to understand left curve shifts. Left curve shifts cause hemoglobin to latch onto oxygen and to hold it more tightly. And leftward shifts are associated with lower metabolic activity. So this is the opposite of rightward shifts. If you have lower Ca2 or higher pH or lower temp, all these things will cause the hemoglobin dissociation curve to shift in this direction, like what I've shown on the slide here. And then the P50 decreases with leftward shift, the opposite of what happens with a rightward shift. Now let's talk about a very important substance found inside red cells that can affect hemoglobin and oxygen, and that substance is 2,3-bisphosphoglycerate, also called 2,3-BPG. So 2,3-BPG is found inside red cells, and it shifts the hemoglobin-oxygen dissociation curve to the right. So it moves it from something like the red line here to something like the blue dashed line here. And as we've been discussing, anytime that happens, that promotes oxygen release from hemoglobin. And because 2,3-BPG promotes oxygen release, it's actually a negative allosteric effector. We talked earlier about how hemoglobin is an allosteric protein, and oxygen, when it binds hemoglobin, has a positive allosteric effect. But 2,3-BPG has a negative allosteric effect because it promotes the release of oxygen molecules. So anytime the levels of 2,3-BPG inside the red cells go up, this is going to decrease the oxygen affinity of hemoglobin, and it's going to cause more oxygen to be released by hemoglobin and therefore more to be delivered into tissues. And so because 2,3-BPG promotes the release of oxygen into tissues, it's produced in response to hypoxia. And we'll talk more about this in a second. But in other words, when the body senses hypoxia, red cells will produce more 2,3-BPG, and that will allow them to release greater amounts of oxygen. There's a tie-in here with biochemistry. So in the biochemistry section, I talk about these steps which are part of glycolysis. One of the intermediates in glycolysis is 1,3-bisphosphoglycerate, and some of that gets converted by an enzyme called BPG mutase into 2,3-bisphosphoglycerate. So in other words, 2,3-BPG comes from glycolysis. The red cell sacrifices a little bit of its ability to make ATP in order to make 2,3-BPG, and that's how it's produced inside the red cell. So as I said before, BPG levels go up inside of red cells anytime there's chronic hypoxia, because the BPG will interact with hemoglobin and allow greater release of oxygen into tissues. So some of the situations where you can see high 2,3-BPG levels in red cells are patients with COPD who are chronically hypoxic. Also at high altitude, there can be chronic hypoxemia and hypoxia. And then anytime a person has a chronic anemia, their tissues will be chronically deprived of oxygen because there aren't enough red cells. And over time, this can lead to the production of 2,3-BPG as well. Let's talk briefly about high altitude because 2,3-BPG plays an important role in how our bodies adapt to living at high altitude. So at high altitude, there's a low PaO2, and by P big AO2, I mean the inspired partial pressure of oxygen. There's lower atmospheric pressure at high altitude, and that means that the air we inspire has a lower partial pressure of oxygen. So initially, when you ascend to high altitude, this can lead to hypoxia. And the initial response of the body is to simply hyperventilate and try to bring in more oxygen by increasing the respiratory rate or the tidal volume. But with chronic exposure to high altitude, the hemoglobin-oxygen dissociation curve will shift to the right. And the reason it does this is because of production of 2,3-BPG inside of red cells. So if you look at this graph I've drawn on the screen here, at sea level, the PaO2 is about 100. That leads to a PaO2 in our arteries of about 100, which fully saturates hemoglobin. But if you climb to the top of Machu Picchu, which has a very high altitude, the PaO2 can be as low as 75 or even lower. This can lead to a situation where the hemoglobin leaving your lungs is not 100% saturated, but is at some lower percent saturation. And that means less oxygen is going to be delivered to tissues. Initially, your body will simply hyperventilate, but over time, the curve will shift to the right. And that means that even with the lower PaO2 of Machu Picchu, by shifting to the right, you can fully saturate hemoglobin and therefore deliver more oxygen to tissues. 2,3-BPG also plays a role in the function of fetal hemoglobin, so let's talk about that now. So fetal hemoglobin is hemoglobin F. It has 2 alpha chains and 2 gamma chains, and it's the predominant hemoglobin from 8 weeks of gestational age in utero all the way until about 8 weeks after birth. In utero, it makes up about 90% of fetal hemoglobin. The levels fall a few months after birth, and they reach the adult levels at 1 year. And in the adult, hemoglobin F is less than 1% of total hemoglobin. But the reason babies in utero have so much hemoglobin F is because hemoglobin F has a much higher oxygen affinity compared to adult hemoglobin, hemoglobin A. The dissociation curve for hemoglobin F is left shifted, and that's a good thing because the PaO2 in the baby is only 40. Remember, the baby doesn't have lungs, it's not breathing air, it has to get oxygen from the placenta, and that leads to a relatively low PaO2 of 40. So if not for this left shift, very little oxygen would be present in the bloodstream of the baby. So just to make this clear, in an adult breathing air with normal lungs, oxygen is going to fully saturate, just like what I've shown in this red curve here. But in the baby with a PaO2 of about 40, if it were operating on the red curve, it would only be saturating hemoglobin at around 75% on my example shown here. That would lead to much less oxygen delivery to tissues. But by shifting to the left, now even down here with a PaO2 of 40, we're going to get close to 100% saturation of hemoglobin. And that's the benefit of hemoglobin F having a left-shifted dissociation curve. So the tie-in with 2,3-BPG is that the left shift of fetal hemoglobin is caused by altered 2,3-BPG binding. 2,3-BPG binds gamma chains poorly. It's much better at binding beta chains like you find in adult hemoglobin. So with less ability to bind 2,3-BPG, the oxygen affinity for hemoglobin increases through a left shift. Remember, 2,3-BPG binding normally shifts the curve right, but because 2,3-BPG can't bind the hemoglobin in the baby as well, the curve will drift over to the left. So here's a slide summarizing everything we've talked about in regards to right shifts and left shifts of the hemoglobin oxygen dissociation curve. I won't review all these things because we've already talked about them, but make sure you understand this table. Don't just memorize it, make sure you understand it, and then you'll be able to answer lots of questions on your board exams about hemoglobin oxygen dissociation curves. I'll show you one slide on myoglobin. This is another protein that can bind oxygen. It's found in skeletal muscle and in heart tissue. It's made up of a single peptide chain, not 4 like hemoglobin, and so it can only bind 1 molecule of oxygen. And so because of this, it has a very simple dissociation curve. It just goes up and then plateaus out at a peak. It doesn't have that S shape of hemoglobin because, as we talked about before, the S shape comes from positive cooperativity. And then because of the shape of the myoglobin curve, it's always got a higher amount of binding of oxygen at all partial pressures, and that's just a difference in the way myoglobin works compared to hemoglobin. For the rest of this video, I'm going to talk about some substances that can interact with hemoglobin and affect oxygenation of tissues. And the first one I'll talk about is carbon monoxide. So carbon monoxide binds to the iron in heme with a much greater affinity than oxygen, 240 times the affinity of oxygen. And this forms a structure called carboxyhemoglobin. And this is bad because it blocks oxygen binding sites. There's less oxygen that can be absorbed by hemoglobin. This creates what's often described as a functional anemia. Basically, even though you have a normal amount of red cells in hemoglobin, you're functionally anemic because many of the binding sites for oxygen are blocked by carbon monoxide. Not only does it cause a functional anemia, it also affects the binding sites for oxygen where there's no carbon monoxide. It's an allosteric modifier of hemoglobin. It shifts the dissociation curve to the left. So this basically creates a double whammy. First of all, you get this functional anemia where carbon monoxide blocks oxygen binding sites. And then whatever oxygen hemoglobin is able to bind, it cannot offload because the curve is shifted to the left. So here's a depiction of how carbon monoxide affects the hemoglobin dissociation curve. So the blue curve is normal. The red dotted line is a patient with significant amounts of carboxyhemoglobin. So first of all, the carrying capacity of hemoglobin is reduced. That's that functional anemia created by carbon monoxide blocking oxygen binding sites. And then the curve is shifted left, so whatever oxygen is bound by hemoglobin is less able to be released into tissues. So patients exposed to carbon monoxide usually develop nonspecific symptoms. Headache is the most common. They can also report malaise, nausea, dizziness, but none of these things are going to make you think of carbon monoxide poisoning right away. Usually you suspect it based on history if the patient was exposed to fumes from a car or a house fire or something along those lines. There's a classic but very rare clinical sign, that's cherry red lips. So carboxyhemoglobin is red. So in a patient who has nonspecific symptoms and maybe even reports a little bit of shortness of breath, you don't see blue lips and cyanosis like you expect. Instead, they're cherry red, and that's from carbon monoxide poisoning. A pulse oximeter is a device you put on a patient's finger, and it will tell you the percent saturation of hemoglobin. It's often normal in the setting of carbon monoxide poisoning, and that's because the pulse oximeter can't differentiate carboxyhemoglobin from oxyhemoglobin. So it may say the patient is 98% saturated, but it can't tell you that much of that saturation is related to carbon monoxide, not oxygen. You can make the diagnosis by measuring a carboxyhemoglobin level. Normal's under 3. Smokers can have a level of 10 to 15, and above 15 suggests poisoning. And you always want to remember this fact about smokers. Sometimes in a board question, they'll tell you a patient is a heavy smoker and has a carboxyhemoglobin level of 10. That's probably from the cigarettes and not from carbon monoxide poisoning. And the treatment is with oxygen. If the patient inhales oxygen, it will bump carbon monoxide off all of those hemoglobin sites eventually. And so I've placed a table at the bottom of the slide, and these are all the things you want to remember about carbon monoxide poisoning for step 1. So the amount of hemoglobin in the blood is totally normal. There's no problem there. But the SaO2, the amount of oxygen bound by hemoglobin, is reduced, and that's because carbon monoxide is blocking those binding sites. Your PaO2 is determined by your lungs, and they're working normally in carbon monoxide poisoning, so the PaO2 will be normal. But then the total oxygen content of blood is reduced. And that's because despite the normal hemoglobin and normal PaO2, you have less binding of oxygen to hemoglobin. Okay, next let's talk about methemoglobinemia. So most of the iron found in hemoglobin is in the reduced state, the Fe2 plus state. But a small amount of the iron is oxidized in the Fe3 plus state, and we call this methemoglobin. And it's unable to bind O2 because of the iron is in the 3 plus state. Now usually this is just a tiny amount of the hemoglobin found in our body, but if you develop excess methemoglobin, that can lead to hypoxia. And so once again, I've put a table at the bottom of the slide here. These are the things you want to remember about methemoglobinemia. The amount of hemoglobin the patient has is normal, but the SaO2 is reduced, and that's because much of that hemoglobin has iron in the 3 plus state and can't bind oxygen. The lungs are working, so the PaO2 is normal, and the total oxygen content of blood is reduced, and that's because of the reduced SaO2. Usually methemoglobinemia is acquired because of exposure to certain drugs. So local anesthetics like benzocaine are classic triggers for methemoglobinemia. Also nitric oxide, which is sometimes administered to babies for pulmonary vasodilation in the NICU. Also nitrites, which can be given for a variety of reasons like vasodilation. They can cause methemoglobinemia. And then dapsone is a rarely used antibiotic. It's also been associated with methemoglobinemia. The treatment is a substance called methylene blue or vitamin C. Both of these things are reducing agents, so they will convert the iron from the 3 plus back to the 2 plus form, and they will resolve the patient's symptoms. So the classic scenario of a patient with methemoglobinemia is going to be an endoscopy patient who had benzocaine sprayed in the back of their throat for analgesia, so the endoscope could be passed down into their esophagus. Or you could see it maybe in a premature baby who's given nitric oxide for pulmonary vasodilation, or a patient exposed to any of those drugs I mentioned on the last slide. But after exposure to the drug or after the endoscopy procedure, the patient will feel short of breath. If you draw their blood, a classic finding is the presence of chocolate brown blood, and that's because methemoglobin has a chocolate brown color. The pulse oximeter is variable. It will often show some degree of hypoxemia in the 80s or 90s, but sometimes the oxygen level can appear normal, so you have to have a high degree of suspicion for this complication. And one of the most important clues to methemoglobin on board questions and in real life is that when you administer oxygen to the patient, they still feel short of breath. So if you're giving them lots and lots of oxygen, their pulse ox appears to be normal, but they're still saying they're short of breath, and they've been exposed to one of these drugs, that's when you should think of methemoglobinemia. If you do a blood gas and measure their PaO2, that's going to be normal. We already talked about this. The lungs are working, so the PaO2 is normal. And so the way you make the diagnosis is by sending a blood sample to the lab and measuring the methemoglobin level, which will be elevated. And that concludes our module on hemoglobin.